I'm Dr. Jeff Clement. Welcome to Module 6 of our Business of Healthcare class. In this module, we're going to be discussing the revenue cycle for healthcare organizations, how reimbursement is calculated, and some key takeaways for PAs, both in clinical practice and who may be in leadership or management roles. So I want to start off by asking you to think of a common patient encounter in whatever setting you are most familiar with, whether that's the ED, primary care, any type of setting. And so think about that moment. You walk into the room with the patient, you start to get a sense for what might be going on. Maybe it's an appointment and you have a good idea, it's a minor procedure, or maybe it's, in the ED or standalone ED, and, somebody has a small cut on their finger that needs some stitches. How much will be reimbursed for that encounter? How much revenue is the organization going to get for that encounter? And I think for a lot of folks, they have no idea, right? Like, even if you maybe have a sense, maybe the EHR shows the patient's coverage up, on the screen. I know in Epic, a lot of times for Regions Hospital and a lot of the provider screens, we could see what coverage the patient had pretty easily. But even if you have that information, chances are you probably don't really know what your organization's gonna take in revenue from that. And so I love this emoji. I don't know, we have no idea how much we're gonna be reimbursed for this. And it's one of the things that sort of sets healthcare apart, and not necessarily in a good way, as we'll talk about, where the folks providing the core of the service, like as the PA, like the one taking care of this patient, deciding what we're going to do for the patient, being like, I have no idea what this is going to cost you, the patient, or even how much my organization is going to take in for this service that oftentimes is very expensive, right? And so then sort of extending beyond that, what tasks and responsibilities do you have that don't generate any revenue, right? So think about a lot of the things that you do day to day. Chances are that a lot of them are not reimbursable. And some of that sort of makes sense. Like, it's not tied to a specific patient. Like, let's say you're in sort of a preceptor role of some kind. And you're providing some mentorship or guidance to a new PA. Well, that's not really something you can bill to any one patient or any one insurance plan. So sure, okay, we're not going to get reimbursed for that. But there's a lot of patient interactions that are not reimbursable either and don't generate any revenue. And so one of the key takeaways, talking to a lot of PAs, is, does everybody understand the importance of those efforts? Because sometimes things that don't generate revenue don't get the visibility that they probably deserve. And as a result, people may not really understand what it is. Like, what do you do here? Actually, what I do is really important here. And so understanding how this system works will let you better advocate for yourself and for other PAs. And if you're in a leadership or management role, make sure you're able to lead and run that organization in a sustainable way. So the objectives of this module are to describe the provider revenue cycle and its key stages, to explain prospective payment systems, DRGs, and bundled payments. These are just a lot of the different ways that reimbursement is calculated. And then analyze how documentation and provider queries can affect the reimbursement process. We'll start by talking about the provider revenue cycle. And I'll caveat this by saying that it's going to be different for everybody. And I know that what I'm going to show on here does not exactly match what any organization does. So I'm telling you up front, this is wrong and does not match your organization. The question is, how wrong is it? Okay, so it's an archetype, it's fairly common, and the general steps overall align with what a lot of people experience. But I know that there are going to be some differences out there. If you work for the VA, for example, a lot of this probably won't necessarily be relevant because veterans have VA coverage. There's really not a billing cycle, but there is still some kind of a budgeting cycle. So this gives you, potentially some insight. There's other places where it's completely different. So if you're a PA working for a workplace clinic, you providing essentially like primary and urgent care on site. Let's say at General Mills. General Mills sets up an annual contract with your organization to have a PA on site 5 days a week so that employees can just pop right down. They don't need to leave work. Everybody benefits. And an individual patient interaction doesn't necessarily then generate additional revenue for the organization. All of that is bundled together in the total cost that's paid as part of the contract. The process is generally going to be broken down into 4 main stages. And this is sort of with a hospital inpatient view on things. It's going to be a little different inpatient versus outpatient. But again, this is sort of the general archetype. So before any patient contact is made, we should have all of our revenue cycle management policies and technology infrastructure put into place. So we've got all of this stuff that's built. We've got our system, we have our policies, our training, our people are all in place. And we've also done whatever payer contract negotiations we're going to be able to do. So we're going to set the rates for the year. Now, obviously, if you're working for, let's say, M Health or Hennepin County or Regions or whoever it is, you're going to have those negotiations with the private payers, with Blue Cross Blue Shield, with United Healthcare. You're not really going to be able to negotiate much with CMS, for your Medicare patients. The CMS is going to say, hey, here's what the rates are this year, and you pretty much have to figure out how do you make that work. Okay. So then there's a patient contact starts. Okay, so maybe an individual walks into the ED, or there's some scheduled surgery. They come in, they're going to register. So you've got all that scheduling and registration, pre-certification and insurance verification, figuring out what their coverage is, all those types of things, and then you start providing medical services and documenting those services. And most hospitals are going to start the oversight process at that time. Every day for all the new admissions, they're going to start reviewing things to make sure that we've got all the proper documentation, that things are in place, so that we can have an effective revenue and billing cycle, rather than wait until after the patient's discharged, they've left the hospital. Maybe it was we had a traveling PA or a per diem PA, and now they've gone back to wherever they work most of the time, and they're not on site anymore. Okay, so that all these things increase the delay, and so we want to try and resolve all these things as quickly as we can, even while patient contact is still ongoing, the patient's still an inpatient. Okay, so then we've got this charge entry and coding. Okay, this typically takes about 15 to 19 days. Again, going to depend on the organization. This is something that AI could potentially help with quite a bit, speeding up this process. But this is what's called our charge entry lag. So it's the difference between once these services are provided and we actually start entering these charges and coding them. And there's a substantial cost associated with that, and it's pretty intuitive. So think about your own personal life. You get paid on payday, and we all have our bills and everything. But the longer the delay between when you do the work and when you get paid, just the more difficult it becomes for you. If there's a much longer delay between when you perform some services and you eventually get paid for it, that can make it hard to budget. It can make it hard to know what's coming in, when you're going to get paid, all those things. And the same is true for an organization. And then after discharge, we've got the billing, claims prep, and editing. So that's more on the organization side. And then you submit those claims, and then you're going to deal with the inevitable denials, so managing those denials and submitting appeals as appropriate. And then finally, collecting the cash and getting the money from the payer and posting. So posting is the accounting term for putting it on the ledger and saying, okay, yep, we've received this payment. And on average, now this study was a little bit dated, but it's sort of the best number I could find. Typically about 57 to 68 days where these charges are sitting in what's called accounts receivable. So thinking back to like our accounting and financial management, we've got this bill that is sitting in accounts receivable. So we've done all the work, we've provided all the services, we spent all the money, and you can see that like by that duration, we've paid all of our staff for the work that they provided during that time. And in the case of either a salaried or hourly or per diem, or basically anything other than a PA in private practice who's doing their own billing, which certainly could be a thing. But let's say if you're working for a hospital and you're paid a salary, you've received your paycheck for that work, and now the hospital is having to go back, close the loop, and it's going to be several months before they get paid for that work. Okay. So we can sort of walk through it in a little bit more detail, and there's the of the providing the actual services. Okay, so this is what's taking place during the care. So you put in an order, let's say for a patient to get a particular procedure. They come in, they register. Okay, and then the charge capture. That's where we're going to actually capture that, hey, this happened, and the service was provided, and now we're gonna bill for it. Okay, we're gonna go through the diagnosis and procedure coding and auditing. That's where we say, okay, this happened. What exactly are we gonna bill for? And let's make sure we've got all of our paperwork, that supports that. Do all of our discharge processing, and so notice for the inpatient process, the diagnosis and procedure coding is ideally happening while the patient is still there. Maybe that's not always the case. Again, depends on the organization, but is sort of a nice ideal. We go through that billing and claims process. For claims that are denied, we resubmit them, and then hopefully we get that reimbursement from that third party. Okay, so then they give us the cash. If they say nope, we're denying that claim, then you're going to go through an appeals process, back to go through that appeals process, go back to the third party, hope that they pay. If they deny the claim or say, we've already paid our what we're going to pay, then you go into the patient billing, you submit, you've got this outstanding balance that the patient has to pay cash for, and then the patients what they'll pay their portion, so their copay, their coinsurance. You'll post those, so those green boxes representing when cash actually comes into the organization. And then, this is a pretty contentious topic. Most healthcare organizations, though, do send bills to collections ultimately. Medical debt is a very hot topic. There's a lot of research in this space, the impact of it. But this is the reality of what a lot of healthcare organizations are doing. So just to be clear, I'm not presenting how you necessarily should do it or what the ideal should be. This is a positivist view, which is ironically not always super positive, but it is what happens. This is what takes place, not necessarily what should take place. So just to be clear, that's yeah. All right, and then finally, whatever money comes in from the collections agencies, and again, that's going to be like pennies on the dollar usually, and a lot of that debt ultimately gets written off. Okay, so we've sort of gone through the process, but who are these entities? All right, and so for a lot of us, we're very familiar with the providers. Okay, so this could be a hospital. So think regions, Hennepin County. This could be you as in private practice. Whoever is providing that service. Okay, and then we have CMS. Okay, Centers for Medicare and Medicaid Services, way over here, the largest healthcare payer in the world. And so they're going to be paying for a good chunk of the services that many of our employers are providing. But so, how does the money get from CMS to me? Okay, there's a bunch of intermediaries and sort of in the middle. And then, of course, there's also the third-party payers that we're all very familiar with, Health Partners, United Healthcare, Blue Cross Blue Shield, that we're all very familiar with. So they also are going to be paying for some of our patients. where does the money come from? So we've got this, for Medicare, we've got this intermediary, or these group of intermediaries called MACs. They're Medicare Administrative Contractors, okay, and there's a handful of them based in different regions in the country. For here in Minnesota, we would fall under National Government Services. So they're sort of sitting between CMS and us, so sitting between mHealth, Fairview, and CMS, and that's who we're going to be submitting claims to. So all the money is provided to NGS by CMS, along with a contract to administer Medicare claims and services for our region. Okay. We're not going to send them directly to the MAC in, again, most cases, and we're to all of these other providers, okay, or payers, excuse me. Normally, most organizations use a clearinghouse. And so the clearinghouse is an intermediary that sits on both sides, or has relationships on both sides with all of these organizations. And so you'll submit the claim to the clearinghouse, okay, and then the clearinghouse will send that claim to the right place. So the private and Medicare Advantage will be sent to that third-party payer, and the Medicare claims will be sent to the MAC. So the big advantage there is you don't have to figure out who do I mail this claim to, right? Of course, they're not mostly on paper anymore, but back in the day, they were. But even today, do you want to go through all the work of setting up relationships with all of these different payers and setting up the digital connections between your EHR system and then your billing system and United and Health Partners and Blue Cross Blue Shield and all of the different payers, figuring out what goes where. Oh, this is a drug claim, so this is going to go to the pharmacy benefit administrator. This is going to all the different claims. This is a medical equipment claim. This is going so it gets very complicated very quickly, and the clearinghouse is going to manage all of that for you. So you send all of your claims to one place. They farm them out from there. Okay, and then once the claim is submitted, then the payer will remit the payment directly to the provider, assuming it's. Fortunately, of course, we no longer have to submit paper claims. In most cases, we're doing this electronically, right? So we're sending these claims from our EHR billing module or the practice management system to the clearinghouse. So that's Change or Availity, Waystar, whatever the case is there. All right, and so this is going to be sent in this 837P professional healthcare claim X12 5010 format. If you really want to nerd out, you can look at these right here. This HI-ABK E119. That's the bulk or the most important part of this claim, I think. So HI indicates it's the health information segment. ABK means we're using an ICD-10 diagnosis code, and we're submitting this diagnosis code for E119, which is 11.9. You don't put the periods in there. So type 2 diabetes mellitus without complications is our diagnosis. And so we would read this as the principal diagnosis for this claim is ICD-10 CME119, type 2 diabetes mellitus without complications. And then we can go on from there into the different services that were provided, all that stuff. Okay, so we're going to send these claims to the clearinghouse digitally. They'll be usually the clearinghouse is going to check and make sure that everything looks good. They'll try and provide some service to their customers. Obviously, the practices are paying the clearinghouse for this service, so they try and let's clean this up, or hey, this is missing before we send it to the insurance company, because then if the insurance company rejects it, then we're going to have to appeal and fix it, all this stuff, right? So if it does get sent back, it's going to get sent back using another standard format, 227 CA. Well, actually, either way, you'll get a claims acknowledgement. okay, indicating what is going on here. So we've got right here in the middle, claim 1, 2, 3, 4, 5, 6, telling us what the claim is. All right, and then we've got this STC, so the status here. So A3, it's acknowledging that's yep, we got it, but this is returned because it's unprocessable. 21, we're missing or have invalid information. There's our date. So this was August 26, 2025. The reference internal control number. This is basically just the internal control number associated with it. And then let's see, where do we've got this, so 227, yeah, so this A321, that's really the core of the claims acknowledgement saying, look, you've got some missing or invalid information. Claim is rejected, cannot be adjudicated. So this will need to be fixed and then resubmitted. Really fun stuff. Fortunately, there's a lot of people who do this as their job. Billing and claims is billing and coding, and then submitting those claims is a really important part of most healthcare organizations these days. And there's a lot of software out there to help with that. So fortunately, most of us don't have to deal with it, and that's all getting taken care of. But this next part, I think, is really important for PAs to understand. So calculating provider reimbursement and the idea of these relative value units, or RVUs, probably a term you're already familiar with, right? Okay. So the AAPA maintains PA-specific reimbursement resources. So this one is updated regularly, the Essential Guide to PA Reimbursement. This is a really good resource, and if you're a member of AAPA, not a plug, I'm not a PA, I'm not a member of AAPA, but it's a good resource. And you should have access to it. So it's got some good info and will largely reflect what I'm going to talk about here. Again, just like with the revenue cycle, sort of the process or the life cycle of a claim, it may be a little bit different where you work. This may not be relevant to what you do. And as we'll talk about, it's very different when the payer is Medicare versus a private payer. But understanding this sort of core or how these things are talked about, again, Medicare is the largest payer, so there's a chance that for a lot of us, this is relevant, especially if you're in some kind of a leadership or management position, okay? So the idea of a relative value unit, or RVU, is that it standardizes the amount of work required to provide a specific task. Okay, so, you can kind of be like, dollars do that. Prices are pretty good. Like, they let us compare, how much work it is and the value of fixing a car relative to the value of mowing a lawn, relative to the value of stitching up somebody's laceration, right? Like, how do we compare these? We use dollars. And that's a fair point. But if you're trying to put that kind of logic on the healthcare system, I don't know what to tell you, okay? So the idea, though, is that, look, we want to be able to put a price on these things in dollars, okay? And so we want to standardize or compare different services to each other, okay? So a laceration versus an evaluation versus some particular kind of injection versus, all of these different things. What is the work that it takes to do those tasks, okay? And so they've basically broken tasks into 3 subcomponents, okay? So first is the work effort. And this considers the time, skill, expertise, and intensity of a particular activity. Okay, so some things are a lot easier. Normal child visits, yeah, they're a little time consuming, but they're not particularly hard usually. So not a whole lot going on there. Something much more complicated for a patient with a lot of comorbidities who shows up emergently in the ED. Okay, that's much different than, the 5-year-old who's like, yeah, no complaints, everything's looking good, like height and weight looks good. All right, yeah, I'll see you in a few months, right? So how much work does it take to do this? How long does it take? All those types of questions. So this, as the provider, this is probably where your mind goes, most, and rightfully so, right? Like, this is the person part of the activity. And so just think about your job. Like some patients and some procedures are very intensive and take a long time and are hard to do, and others are a lot easier, right? So that's what this part gets at. Next is going to be the practice expense, okay? So this considers the rent, the supplies, the staff, okay? So, some procedures that are, or things that activities you do don't require anything, right? It's just your brain and talking to the patient and, palpating, right? That stuff's free. But then other things, maybe the provider's hardly involved and it's mostly a nurse or even a tech doing a lot of the procedure, but it's very facility intensive, right? You say, yep, I want to, let's do this. And then you have an MA do an ECG. Okay, well, we need the ECG. We're going to use all the pads. We're going to use all the leads, right? All that stuff has a cost associated with it, even if it didn't take you as the PA personally a ton of time, right? So it could be more intense there. So considering that. And as we'll talk about, I think in a couple slides, this is generally going to be broken out by whether or not it's taking place in a hospital. So if it takes place in a hospital, there's going to be that separate facility fee generally. And so this will be a lot lower because your practice expense is expected to be lower. You might still have admin, you have overhead, you have all those other things. So there's some expense, right? Maybe there's some supplies that you personally paid for, whatever. And even just like admin, bookkeeping, HR expenses, all that type of stuff, right? But you're not having to pay to keep the lights on if you are working at a hospital. So that's going to be a separate fee. If you are doing this at a practice, at an office, freestanding facility, then there's no separate facility fee, so this practice expense needs to be higher. All right, and then last is the malpractice expense. So the cost of professional liability insurance for a given procedure. Some things really don't carry a whole lot of risk, right? Other things are a little bit more risky, or there's a higher potential that the patient's going to come back and there's going to be a lawsuit, and so your malpractice insurance reflects that accordingly. So we add up these things and get our total RVU. Okay. So let's look at some RVUs, the relative value units for a fairly simple repair for a laceration. Okay, so we've got the patient shows up at the ED, et cetera, et cetera. So we'd actually break this out into two separate activities. First, there's evaluation and management in the ED. So we've got a couple different levels. So is this going to be a low complexity medical decision making? Is it going to be moderate, or is it going to be high? Right? And there's different factors. Where is the laceration located? What else is going on? Does the patient have a bunch of other complications? Right? And so there's guidelines to all these things. And fortunately, you don't really have to make this decision like on the spot. Like, well, this is going to be low. This is going to be high. No, you just do your job, take care of your patients. But this is what's going on in the background. Okay. And then, you evaluate it, you do your evaluation and management and say, you know what, we really should stitch this up. Okay, we really should throw some stitches in there. And so then based on the size of the wound, that's going to determine, how complex it is to repair. And you can see that, so we've got, the evaluation and management for a low complexity decision is 1.6 RVUs approximately, which is going to be, that's even more RVUs than pretty like sizable repair, like a 7 centimeter laceration. That's pretty good, it's a pretty solid cut. So I do think a lot of these acknowledge the effort that goes into managing the patient. Okay. And so you can see again, and then like with the lacerations, the size of the wound sort of determines what bucket this falls into. Okay, so let's sort of walk through a sample. Patient presents to the ED with a small laceration on their arm. Okay, so what's going to get billed by the practice? Okay, so first, let's say there's nothing going on. Patient's otherwise healthy. They walk in, they're like, this was me a couple years ago. sharpening a knife and I slipped and I cut my hand, bandaged it up, got the bleeding stopped, bleeding stopped and everything. But I knew right away, it's like, yeah, this needs stitches, right? So I go to the ED and, I'm like, I'm happy. All my vitals are normal. I just came back from a camping trip. I was filthy. So I was like, all right, I gotta, bandage it up, showered, cleaned up. I walk in like, I'm fine, but like I need some stitches, so low complexity visit. They look at it, the PA looks at it and is like, yeah, that needs stitches, right? No big deal. Okay. So they're going to bill 1.6 RVUs for the, basically the judgment, the decision-making expertise of the PA, the practice expense, so the overhead, HR, all the stuff that, is associated with this. Now, because this was, as we'll see in an ED, there's going to be a separate facility fee. So it's not covering the waiting room, the huck out in the front, all that stuff. That's separate. This is just basically that interaction with the PA's effort there. And then malpractice expense, pretty low. Now they could mess up. Like there could be something in there, could get infected, could miss something. So it's not nothing, but it's fairly low. Okay. And then, a small cut. Okay, so then, small amount of work RVUs and then all that. So then we'd add all of those up and we'd get the total relative value unit of this procedure. It's pretty low, right? Compared to like a major surgery. Okay. So now we've got our total RVUs, but you might say, okay, but, providing these services in Minnesota and Minneapolis, yeah, it's not too expensive. It's like way more expensive to do this in downtown LA or San Francisco or New York, right? So then we're going to adjust things geographically, okay? And we're actually going to adjust not the end product. We're going to adjust the work expense, the practice expense, and the malpractice, okay, with a geographic price cost index. Exciting stuff, okay? So Minnesota has the sort of the standard base work expense GPCI. So, sort of saying that like it's not particularly expensive to, wages here aren't particularly high. Okay, so fair enough. And we could see some other places where, they might be a little higher. So, and it's broken out. Some states break things out specifically by city. So this is just a sample of the chart, but you can see like Manhattan is separate from the New York City suburbs and Long Island and the rest of New York. So, Syracuse, New York, Rochester, New York, they're not, particularly expensive places to live. They're nice enough, sure. But it's not Manhattan, right? Rest of New Jersey versus, I guess the other part of New Jersey is not on here. It's probably Newark. And maybe a little more expensive. But Minnesota is all the same. Anywhere in Minnesota, no adjustment to the work expense. So then the practice expense. Okay, so it's a little bit more expensive to run a practice here in Minnesota than, let's say, in Michigan. Okay, so real estate maybe is a little more expensive. So your rent's higher, okay? The other expenses might be a little higher than in some other places. This might include wages that you're paying to your staff, right? So who's paying the HR? Who's paying the accountants? Who's paying the HUC and the patient coordinator? And all those folks, they're not sending a bill to Medicare. So all of those salaries have to be covered, and you can sort of in the model here, if you wanted to think about it, would be like a private practice, right? The PA, the MDs are sending the bills to Medicare, and everybody else, the secretaries, the MAs, all of those folks, the nurses, their salaries have to be covered by the billing, that's sent here. And so when the wages there are higher, the practice expense is going to be a little higher. Okay, then next is malpractice. Okay, so this is going to be governed at the state level generally. So if you wanted to sue somebody for malpractice, you'd be suing them under the laws of the state where the issue took place generally. And Minnesota, interestingly enough, has the lowest malpractice GPCI of any state. So good for us, I guess. And I was like surprised. I was like, really? Like, oh, 0.3, that's pretty low. And then start looking through the chart and was like, wow, it's lower than anybody else. And the reason is that in Minnesota, there are some barriers that make it a little bit more difficult to file malpractice claims. Specifically, you have to provide certification of expert review up front. Basically saying, you know what, I've had a medical expert review my case. They've reviewed the records and they have asserted, and they're going to provide an affidavit that says, based on my expertise as a medical expert, I am certifying that that there was malpractice and that this case should move forward. So basically, providing a statement up front from an expert witness, or a written affidavit statement from an expert witness up front. And so sort of two things, it's going to cost you money to do that. And so, and I think that's the point of this legislation. If you believe that you really do have a claim and you really were harmed, then it's not a big deal for you to say, you know what, yeah, and your lawyer will tell you, you should spend a couple $100 or a couple $1,000 to get an affidavit and have this reviewed by an expert, so that we can move forward. But if you know that you have a fraudulent claim that you're unlikely to prevail on, you're not going to be willing to spend that money up front. And so that's the point. It just provides some protection against not necessarily just fraudulent, but people just like throwing something against the wall hoping that it sticks and that the hospital agrees to settle, right? Because even if the claim is totally bogus, the hospital or your malpractice insurance still has to pay out for a lawyer to defend you. And so even if the claim is bogus, it's going to cost you something. So if somebody files a claim without that, the claim is dismissed with prejudice, and they can't refile it. So it really limits the claims in Minnesota. So fun little trivia there. But that means that, if you compare what somebody in a more litigious state, so it looks like New York, a lot higher chances of somebody filing a malpractice suit. Maybe it's because people in Manhattan, are all Wall Street people. I don't know, and so, the malpractice expense is going to be higher there. Okay, so we adjust all of these numbers by our geographic adjustment, and then we get the total number of RVUs, the relative value of the work, and then we multiply by our conversion factor, which is for 2025, $32.34.65. So down to the thousandth of a penny. Great. So for this service, we would be reimbursed. If I had Medicare to get this laceration stitched up, would be $104.91. All right. Now that is just the provider or the physician, the PFS, a professional fee associated with that. So there'd be a separate facility fee. Okay. All right, so yeah, our RVUs, conversion factor, and then the Medicare price. Okay, so there's some other fees associated with this. Okay, so if this service is provided at an outpatient facility, there's going to be some fees associated with that. So we'll convert these CPT codes for the work that's done to ambulatory payment classification, APCs. Which sort of group all these services together, and they're going to include these basic drugs and supplies. So, the 4x4s and the alcohol wipes and, probably the sutures and stuff would probably all be included in the code for the simple repair. Now, if I was, you determined that I was also super dehydrated when I came in because I was camping and whatever when I cut my hand, and I don't know. And you're like, you know what? We need to pump you with some fluids. Okay, that's probably going to increase the complexity of the medical decision making, but the IV bags, for example, would not be included in this APC for the simple repair, right? Okay, so similar to the RVUs for APCs, ambulatory payment classifications, we have relative weights. Like there's so many terms, so many vocab terms. You do not need to memorize all these unless like this is the core of your job and you may need to really dig into like the details of how specific things are being reimbursed. Okay, so again, the CPT code for the ED visit, the 99283, that was the PA looking at me and saying, yeah, we need to stitch that up. Okay, so the medical judgment of evaluating the patient, deciding how to move forward, that would have a relative weight from the facility perspective of 3.1144. And then the procedure, okay, would have a relative weight of 2.2284, giving us a total weight of 5.3428. So that's what we're going to use now to calculate our facility fee, okay? So for Medicare, we're using this Hospital Outpatient Prospective Payment System, or OPS, for ambulatory services. So anything that's not inpatient is going to be an inpatient prospective payment system, all right? And they're all different. Why? I don't know, because we like complexity. So we're going to calculate a hospital-specific conversion factor, right? This is super, super fun stuff. Okay, so we have this relative weight, and now we need to turn that into dollars. Okay, so the conversion factor for 2025 for Medicare is $89.169, down to the hundredths or tenths of a cent here. Why don't we go to the hundredths here? I don't know, or the thousandths. No, wait. Sorry, last time we went to the hundredths of a cent. Here we're going to tenths of a cent. Why is the other one 4 decimal places? This is 3? I don't know. All right, so now we're going to adjust this. Okay, so first we consider 60% of the conversion factor. Okay, so 60% of 89.169 is 5350. Okay, and we're going to adjust that by a geographic, hospital-specific conversion factor to account for local differences in wages. So for, I pulled it for Hennepin County Medical Center. It's the same for mHealth and Regions and all the hospitals here right in the Twin Cities. It's pretty much the same. Okay, so instead of saying, they're basically saying, yeah, but wages are a little higher. Minneapolis has a city-specific minimum wage. There's some additional requirements. Minnesota has paid family leave, all these things. So, wages are going to be a little higher here than right across the river in Hudson, okay? Assuming they can, because this is not, and this as a facility fee does not consider the cost of the PA, doctors, the providers, because their services are being billed separately, okay? So it's not, hey, this is way out in the middle of nowhere. Are we going to be able to convince PAs to move out here? No, because that would be considered under the RVU calculation and the geographic conversion here. This is the other folks working in the hospital, okay? So we have a small adjustment there, and then we take the other 40%, which is the non-labor portion of the conversion factor, 40% of 89,169, 35.67, which gives us $90.20. Okay, so that is going to be the Hennepin County Medical Center conversion factor for 2025, $90.20. CMS certification number 240004 if you wanted to look something up. Okay, then the conversion factor is multiplied by the relative weight to calculate the payment under this outpatient prospective payment system. So 90/20 is our HCMC specific conversion factor. Wherever you work, again, if this is hospital-based, all right, for not inpatient stuff, ambulatory stuff at the hospital, 90/20 times 5.3428. That's from our relative weight calculation. You did a low complexity medical decision-making evaluation and a simple repair of a laceration, less than, 5 centimeters or something. And that tells you that the facility fee is going to be $481.92. All right, and now let's assume that the PA is a salaried employee, or just either salaried or hourly based, but you're an employee of a specific health system and not of a separate medical practice, right? So you're not doing your own billing, right? I work for Health Partners. You work at Regions, Lakeview, Methodist, and your relationship is just with them. You don't do any separate billing, okay? So they're doing all of the billing. So what is the hospital going to receive from Medicare for this procedure? They will get a total of $586.83. So the $481.92 for the facility fee and the $104.91 for the basically the professional services of the provider in this case. Okay, so there you go. Okay, a little bit different on the inpatient side. So we have the MSDRGs and the APDRGs. Okay, so we'll talk about those. So basically two separate systems. MSDRGs for Medicare patients and came first, and then the all patients DRGs came later for third-party payers. So inpatient care is generally going to be reimbursed under these diagnosis-related groups, which bundle up care. So first you're going to specify stuff as being part of an MDC, major diagnostic category, basically by body systems. And then you've got the DRGs, which will look at the primary and secondary principal and secondary diagnoses. Okay. So these two systems. So Medicare is going to use the MSDRG, medical severity diagnosis related groups, and third-party payers are going to use APDRGs, the all patients refined diagnosis groups, diagnosis related groups. Okay, so APDRG expands on MSDRG. So MSDRG came out, and third-party payers said, well, this is cool, we like it, but the issue is it was developed by Medicare. Who's in Medicare? Primarily older people. It's a smaller subset of the population, didn't really cover all of the categories. And also, they tend to be older, so they tend to be a little bit more sick, and just doesn't really capture the complexity of patients as well, and really doesn't account for kids. So we need better stuff for infants and peds in particular. So they work with 3M, and 3M develops APDRG. So it adds, instead of 3 complexity categories, has a 4th, better accounts for patient age, psychiatric conditions, some additional stuff. Okay, do you need to care? Should you be thinking about this in a clinical setting? Probably not. Almost never. Is this going to affect how you do your care? I would say almost never. This is something that takes place on the back end. So you've done your care, you've done your documentation, and then it's on your billing and coding folks to figure out what DRG do we bill this under. Where this can come back though is, as we'll talk about in a second, how things are bundled. So if you are in a management role and you're trying to figure out where our revenue comes from and where our expenses are going, this can really start to play a role. Probably not so much like differentiating between these two, but understanding DRGs definitely can make a difference. Okay, so let's look at MSDRG 383, an uncomplicated peptic ulcer with major complications or comorbidities. Okay, so that's going to make it a little bit more different. Okay, so the principal diagnosis codes could be some different types of ulcers, maybe the acute, chronic, gastric, duodenal, different, the location can vary. So we can see that, the diagnosis is, this DRG, or this diagnosis related group. The care from a billing perspective of a lot of different things is pretty similar. So we say, hey, for simplicity's sake, we're going to take a bunch of different things and say, hey, if you're doing any of these, all the care associated with them for the patient while they're an inpatient is bundled under one package. Okay, the value meal approach. Okay, so you get all the stuff and it's all in there, and whether you want the cheeseburger or the chicken sandwich or whatever, it's all the same price. Pick what you want. There you go. And we're not going to bill for every tiny little thing associated with caring for that patient, right, while they're in the hospital. All right, and so for this DRG, diagnosis-related group, okay, it has a relative weight of 1.3234. And then some of the other things that are going to be considered are the geometric mean length of stay and the arithmetic average length of stay. So these are two terms. Again, as you start to move into maybe an operations management or a leadership role, you might start to think about these things. The geometric mean we don't really use in a lot of other settings, but it's reported in all of the Medicare stuff, and it's very often discussed in length of stay calculations. So basically what we do is we multiply everything and then take the nth root. So, with our normal average, or arithmetic mean, or average length, the average length of stay that is the standard average that we're all used to. Add everything up, divide by how many you have, right? So if I have 8 and 10, I add 8 plus 10, and I divide by 2. Average length of stay is 9 days. Okay. Geometric mean works a little bit differently, and instead of adding them up, we multiply. So if we had, let's say, I'm not going to embarrass myself by trying to do one off the top of my head. I should maybe throw a slide in there. Yeah, you probably don't care. We would multiply, so we've got 8 times 10, all right, so we have 80, and then since we have two values, then we take the square root. If we had 3, we take the cube root, and so on and so forth. So square root of 80 is like 8.6 or something. It's going to be closer to 8 than to 10, all right, because 9 squared would be 81, so we know it's less than 9. So the effect, though, is that it's going to, these high values are not going to influence it as much, because a lot of our patients are going to be, they're sort of going to, you're going to have a bulk of your patients. It's going to take, I don't know, 3 to 4 days after a given procedure. And then one of your patients takes 9 days to discharge, right? The arithmetic mean is going to be really swayed by those outliers. The geometric mean, not so much. So it just helps us be a little bit more robust to those outliers who had the weird complication, the weird comorbidity that's not really standard, okay? All right, so we will then multiply. Again, it's another conversion factor. So by the base rate, we're going to adjust that geographically and get what's called the hospital standardized amount. Again, another great term that really doesn't tell us a whole lot. Okay, and so multiply that by the relative weight. So the reimbursement for caring for this uncomplicated peptic ulcer would be about $8,700. Okay, and what is included in that $8,700? Notice we're not billing separately for every little thing. So room and board's going to be included. Medical, surgical ward, step-down unit charges, nursing services, linen, dietary services, all this stuff. A lot of your pharmacy stuff is going to be included. Now, some meds might fall outside of this and be billed separately, but a lot of your basic meds that you expect to use as part of this are going to be included in the DRG. And your standard lab tests. Now, what if you're like, whoa, what's going on? This patient might have something else. We need to check on that. Radiology. Okay, so standard, say like abdominal x-rays, CT scans, standard biopsies, all the sort of standard stuff that you expect to include for this patient, that, yeah, this is pretty normal in caring for this patient. All that's going to be included in the DRG and not billed separately, okay? And accurately documenting the cost of care is really, really important here. And making sure to bill the correct DRG, again, not something that you as the clinician need to focus on too much, but making sure that it's well documented so that the correct DRG can get billed makes a big difference. So this is from a study in the kidney transplant setting, basically looking at the reimbursement under these 3 different DRGs. So kidney transplant with hemodialysis. So, if you need to do some dialysis in the hospital, a lot of times the hospital is actually going to be paying, somebody else. So like at Regions, there's a separate DaVita dialysis unit in the hospital, right? But DaVita's charging the hospital for every patient they care for. So if you have to do dialysis, it's going to be a lot more expensive, right? And you can see that the weight, the MSDRG weight, is higher than if you don't have to do hemodialysis for that patient, okay? These two are with hemodialysis. This is with and without the major complication or comorbidity. So you can see if we don't properly, bill, we're going to leave a lot of money on the table, and this difference is substantial. It's going to make a big difference on our revenue at the end of the year. So we want to make sure that properly documenting and then billing properly for these things. Okay,